This program is brought to you by Emory University.
Good afternoon, everyone, and welcome to ECCRI Research Conference. For those of you who weren't here this morning for our cardiology grand rounds, we've got an invited speaker, Dr. Chrisandra Shufelt, who is a dear friend and colleague of mine, who is a professor and chair of the Division of General Internal Medicine at Mayo Clinic in Jacksonville, Florida, and associate director of the Women's Health Research Center at Mayo. She is a women's health internist and fellowship trained in vascular function and biology, as well as women's health from Cedars-Sinai, where she practiced for many years before moving to Jacksonville. She's a certified menopause practitioner and has several national and international leadership roles in the American College of Physicians, the European Menopause and Andropause Society, and the Menopause Society, where she was the past president in 2022. She has co-authored over 200 publications related to hormones and in this area. And her NIH-funded research, she had a K23, and I just confirmed that it was in functional hypothalamic amenorrhea. And she's going to discuss some of her findings related to research today. And thank you so much for doing this for us. I know that she's not feeling well, but has generously agreed to continue to do this virtually for us.
No, thank you, Dr. Mehta, and thank you for having me. I see some really familiar names from in the audience, and it's just an honor to be able to speak about this in front of you. I am so sorry I'm not able to be there in person. Last week I got really bad vertigo, which followed into a pretty bad spring virus. So I am on the upside, but I'm really disappointed I wasn't able to be there in person. I know that the interactions and the discussions go so much further when you can see people's faces and reactions and have more of an interactive conversation. So I would encourage that still, even if it involves interrupting me. This is not really meant. I know this forum is more of a research discussion forum, but I wanted to really have that opportunity and going forward. So this is our beautiful campus view. If you can see, we are expanding pretty dramatically that parking lot is at the very end here is now a carbon beam ion centrifuge building, and we will be the first of its kind in all of North America to offer this service for cancer center. But you can look further off into the east. I used to say west because I lived on the west coast, but now you can see the ocean is right there, and this is a sunrise over our campus. So it's an honor to be here. I'm going to talk about functional hypothalamic amenorrhea and really long-term consequences from a scientific standpoint, not from a clinical standpoint. But in order to do that, I really wanted to give a basic introduction about the research that we've been doing and are ongoing to do. This has been research supported by both NHLBI as well as NICHD, as well as the CTSI grant that came through Cedars and UCLA. So I always say this, I mean, I think you can probably add many additional vital signs to our current heart rate, blood pressure, O2 sat, respiration, and temperature, but really a vital sign is a clinical measurement that indicates the state of a patient's essential bodily function. And there was an eloquent paper put out about 10 years ago by Marcel Cedars, is the lead author, chartered by a session that was done at the NIH talking about the reproductive age vital sign. And so that's really where this body of research started in terms of understanding the fertility status as a marker of a biomarker for future health. And in reproductive aged women, this as well as women entering menopause, we know that timing is of utmost importance when women enter menopause. So this does really lead to the fact that the fertility status or the menstrual cycle could be a vital sign. So we are lucky in that respect that women have a menstrual cycle because we can tell a lot about a body from the menstrual cycle, regularity or irregularity, absence or timing of stopping menstrual cycles, as well as addition to pregnancy. We certainly know that. And so I think this is where women kind of have a slight advantage over the XY chromosome because we have this as a marker. So where do we look at how could the menstrual cycle be a vital sign? And this is publications from the Nurses Health Study 1 and almost 82,000 nurses that had follow-up for 14 years. So Solomon in 2002 noted that the menstrual cycle, they asked about menstrual cycle regularities in women that were nurses in their main Nurses Health Study between the ages of 20 and 35. And despite the definitions that were given, regular, usually irregular or very irregular, no periods, you can see that the hazard ratio for coronary heart disease went statistically up for trend. And that was really the first notice that the menstrual cycle had something to do with overall cardiovascular health. But if you read this discussion that was done in 2002, and I was just at Brigham last week or 2 weeks ago, and we had a discussion about this paper because it really did focus on the fact that a majority of the discussion was about PCOS or polycystic ovary syndrome, which was thought to be the main driver for this irregular status or no periods. And so, what is really missing from this data is to break down what those women with amenorrhea versus very irregular cycling looks like. And that's what we're doing now, looking at Nurses Health Study 2 to really phenotype out the PCOS trait versus the non-PCOS trait, or what we're talking about for a hypothalamic amenorrhea trait. The menstrual cycle characteristics can serve as a biomarker for future health, and this was really the Nurses Health Study 2, published in 2022 by Wang and Jennifer Stewart. And you can here clearly see that on the left-hand side for cumulative incidence of cardiovascular disease, menstrual cycle regularity, the more irregular indicated by the gray line, as well as no periods, were indicated over time if over their age follow-up that they had higher rates of cumulative incidence of cardiovascular disease. And then the menstrual cycle length, so the time in between the menstrual cycles, if it was greater than 40 or too irregular to estimate, that's also indicated by this light gray bar here. So another strong signal that not only irregularity, but if there was a menstrual cycle gap that was too long to see, to estimate, that was also strongly indicative of cardiovascular disease, even if you look and lump the following three categories together below. It really meant that if you have such irregular cycles that you cannot recall or to estimate, or they were greater than 40 days, as opposed to the latter three. Both irregular and long menstrual cycles were associated with this increased rates, but here we go. However, these analyses did not differentiate between the underlying cause of the irregular cycles or the amenorrhea. And the results really did emphasize, again, polycystic ovary syndrome, which is as important of a marker for women's health, but it does really speak to the fact that it's lumping and not splitting the causes of irregular menstrual cycles or amenorrhea. Again, Nurses Health Study 2 talked about, now we're talking about age of cycle irregularity. And so if you were between the ages of 14 and 17 and had always irregular cycles or no period, higher risk of premature mortality. So this doesn't just necessarily speak to cardiovascular disease. These are women without cardiovascular disease, cancers, or diabetes, and they had a 24-year follow-up. If you had irregular cycles between 18 and 22, again, higher incidence, a 37% hazard ratio. And then between the ages of 29 and 46, accounting for no contraceptive use, if you had always irregular or no periods reported during this period, 39 relative risk hazard ratio, increased risk, and all statistically significant. So again, British Medical Journal publication by Wang in 2020 really started to build out this pattern that was seen in a largest observational study to date. So to go into some of the causes of secondary amenorrhea besides polycystic ovary syndrome, I wanted to define what functional hypothalamic amenorrhea is. It is the underlying cause is actually in the brain, in the GnRH pulsatility loss. So it's not an organ problem at the ovary level. It's a suppression of the GnRH pulsatility in the brain, and this is due to either underlying stress, over-exercise, or restricted eating. It doesn't necessarily have to be an eating disorder. It is a disordered eating pattern. And we've looked at caloric intake in these women compared to age-matched controls, and their calorie consumption is very similar. It's the mineral and content, macro and micronutrient content breakdown that's very different. But what it means is it's absence of 3 or more months of a menstrual cycle in a previously menstrual woman who's menstruating. So this is not primary amenorrhea. These are women who've cycled in the past. Women who have secondary amenorrhea is about 1 to 2% of all women of reproductive age, and this accounts for 35% of the causes, although it has not been really deeply evaluated in large cohort studies as to what the incidence really is. It is a diagnosis of exclusion, so you have to exclude other causes such as polycystic ovary syndrome, prolactinoma, thyroid dysfunction, a lot of different causes need to be excluded, obviously pregnancy. But again, it's this clinical pattern that occurs, but then there's a hormonal milieu. So you get very low estradiol, oftentimes in the teens to 20s. FSH and LH are suppressed because there's the loss of GnRH pulsatility, so those are not on. And what is a larger driver is the LH to FSH ratio is less than 1, as opposed to PCOS, where the LH FSH ratio is greater than 1, oftentimes greater than 2, because of all the follicles that are present. Historically, FSH is fascinating. This was initially described in prisoners, and it was associated with wartime experiences, as well in women who were living in camps or who were refugees. And I think that will come full circle. I'm going to talk about our international registry right now, because there's a lot of people living in wartime situations around the world, and how this incidence might be increasing. There were increased reports in amenorrhea consistently made in World War II, and that were associated with adverse life experiences, living conditions, physical labor, having to move around from location to location outside of being in a camp. The prevalence at that time reached 70% during these times. This was the highest number associated with the highest degree of stress. And unfortunately, the name was coined as psychogenic amenorrhea. So it was thought to be a psychosis associated with stopping your menstrual cycle. And thankfully, that terminology has changed. Just like a lot of terminologies, we're not using the term failure in polycystic or premature ovarian failure in women's health. I think a lot of these terminologies. So now it was shaped into the understanding of a functional. So it is reversible. Hypothalamic is the origin, and it's an amenorrhea, so it stops. So what is the definition that we, or how does this disorder impact long-term health consequences? So you can see here by the bubbles, you have the 3 underlying causes, but they're not usually solely related to themselves. They can be, but it usually is a combination of 2 or 3, which are hard to necessarily measure, especially when you're talking about survey measurements. But then this leads to the loss of the GnRH pulsatility. And so that's the central figure here that's in the yellow that decreases. This doesn't just impact the hypothalamic pituitary ovarian axis. And that's where women have the advantage, because this condition does happen in men. It just happens to be called a different name, and they don't have the clinical signal of the menstrual cycle. So you get loss of the GnRH pulsatility, and then that leads to the drop in estrogen. And there's no feedback mechanism to restart that GnRH, but you also get increase in hydrocortisotropin, as well as increase resulting downstream in elevated cortisol. So unlike menopause, this is a condition that is a global endocrine disruption. It is also impairing the thyroid, and you get decreased total T3. Very important for fetal development is total T3. So when you lose that total T3, and these women are now going in and getting GnRH stimulation for pregnancy, we need to also think about, if you're not in recovery, what is the total T3 doing to the developing fetus? And then we also see this loss of decreased leptin because of the loss of adiponectin of the adipocytes itself, because these women tend to have a BMI less than 21, and decreased insulin and increased ghrelin. But more importantly, understanding the neurokinin pathways that sit above the GnRH pathway. So the kisspeptin, dynorphin, and all the candy neurons that sit above this pathway. Kisspeptin has been studied as a mechanism for perhaps synthetic kisspeptin to stimulate the GnRH to then cause the pulsatility of the generics to recover, but that's still under investigation and not currently a treatment that's available. But what is having low estrogen and high cortisol to a young woman who's on average 25, 26 years old do if that woman doesn't seek treatment or is continuing these behaviors that are then feeding into this endocrine disruption? Well, what has been studied to date and what is being continued to study is there's been reports of cognitive impairment, depression, and anxiety. There's a euthyroid sick pattern that I mentioned with the thyroid function. Early studies showed the FMD for endothelial dysfunction. We used a peripheral vascular test with reactive hyperemic index to look at our studies with endothelial dysfunction, but it makes sense. You get decreased estrogen, therefore you don't have vasodilation and increased in smooth muscle proliferation. But what is this also doing in the setting of elevated cortisol? Amenorrhea and infertility is an underlying signal for this condition, and then you get low bone mineral density and increased risk of fractures. And interestingly enough, there's a different pattern of bone loss in these young women as opposed to menopausal women. Menopausal women tend to lose bone also at the hip and at the pelvis level. These women tend to lose a lot of spine. Bone muscle first. So these are the systemic consequences, and this is just the tip of the iceberg in terms of what we know and is what has been studied to date. The status of stress and atherosclerosis, as many of you on this in this and that call and know about this animal model, and we're part of the research that went into understanding the role of stress and atherosclerosis. But it was really Jay Kaplan's work from Wake Forest, where this was based on the animal models of social status. So you have the dominant, socially controlled Smologous monkey, and then you have all the way to the subordinate monkey and the lack of control. So in illustrating this major source of psychological stress that goes along in this model, they were able to actually rotate cages. And you can see here on the left is the dominant female is the pecking order that persistently harasses the subordinate monkeys. And so what that happens is it causes an elevated cortisol and ovarian disruption. So in this situation, this is an evidence for a primate continuum with the human model. So you have social subordination, luteal impairment, and anovulation occurred in 45% of the subordinate animals, and you get hypercortisolemia, reversible luteal impairment. But this is a stress-related environment that then led to premature bone loss and premature atherosclerosis. And I'll tell you what we're looking at now in these models. Even though it's been almost 2 decades since this studies have been done, there are still frozen samples that we're investigating now. And so in the women, and then paralleling this to our societal stress today, we have psychosocial stress. Could this then lead to functional hypothalamic and ovulatory syndrome on the spectrum of amenorrhea in about 30% of women, hypercortisolism, reversible luteal impairment, and then again, it's a stress related, but could this just lead to chronic disease risk? And are we missing an opportunity to identify these women because oftentimes they look physically fit and physically thin? So is good ovulation a good health? And I would argue that the answer is yes. But the data really that what we looked at and started to investigate was studies from the Women's Ischemia Syndrome Evaluation, or WISE, that Dr. Mehta and I worked on together when we were at Cedars-Sinai, and hypothalamic hypoestrogenemia. So what was being seen and having been in the cath lab with these women doing these microvascular testing or even checking for obstructive disease, there were 95% premenopausal women that were entering the emergency department with chest pain. They were undergoing coronary angiogram for suspected ischemia, and the mean age of these women were 43. If we look at their hormonal values, they did not suggest menopause. So these have all been adjudicated by a hormone expert panel. So these were not women, although their ages are getting over, some of their ages are getting over 40, perhaps closer to what we would consider perimenopause. These were women that were all adjudicated as being premenopausal. They were not on exogenous hormones, and they defined this hypothalamic hypoestrogenemia as a pattern of low FSH and LH and low estrogen less than 50. Sarah Burga was instrumental also from this research itself and involved in that panel. And of those 95 women, 13 had obstructive coronary disease. And of those 95 women, 33 or 35% had this hypothalamic hypoestrogenic pattern when they entered the cath lab because the labs were all drawn the day that they had their angiogram. 26% were non-white, mostly were African American. And then if you looked at their hormonal reproductive status, those that had obstructive CAD, which is in the second bars, as compared to no coronary artery disease, had much lower estrogen, bioavailable estrogen, much lower LH, and lower FSH. So it was a reproductive hormones that were stratified by their coronary artery disease, and you could start to see this pattern. In addition, of those women that had the 13 that had coronary artery disease, 70% of those women had this hypoestrogenic pattern of hypothalamic origin. So the premenopausal women with obstructive CAD were highly likely to have hypothalamic hypoestrogenemia. Well, how could hypothalamic hypoestrogenemia in a 26-year-old lead to obstructive coronary artery disease? And if you look at the barrel down this blood vessel on the far left-hand side, which is a normal artery with a normal vascular function in a healthy individual. Once you hit this double dashed threshold, you now start going into abnormal physiology. Even though the normal artery over time looks normal from a visual standpoint, it has abnormal microvascular function, which then over time leads to subclinical atherosclerosis and possibly obstructive coronary artery disease. So we're looking over a period of what could be possibly a decade, perhaps two, leading from preclinical to clinical manifestation of ischemic heart disease in women. Well, we know postmenopausal hypoestrogenemia, visceral obesity, even PCOS can cause disruptive estrogen levels. And then disruptive estrogen levels can cause hypertension, obesity, and hyperlipidemia. We spent some time talking about the role of menopause in the cardiometabolic risk factors that we know are associated with ovarian aging. We know then this leads to inflammatory milieu. We know autoimmune diseases as well, but then that could cross over into abnormal reaction, microvascular dysfunction, endothelial dysfunction, and then therefore positive remodeling. But what if you have a 26-year-old or a 25-year-old that doesn't have the hypertension or obesity or hyperlipidemia? These are women that look physically fit, but they've knocked out their estrogen. Walking around with low estrogen and high cortisol then create a inflammatory milieu that could then lead towards what we now know as endothelial dysfunction in early stage or subclinical stage of atherosclerosis. So we sought to look at this in our research, and we certainly know that the endothelium plays a key role in vascular health, and we know that it is one cellular layer of the inner linings of all vessels within the body. So, and it can be tested for using a non-invasive test before clinical signs and symptoms really do occur. And we know that it's also strongly and independently associated with things like future cardiovascular disease events, even cardiac death, MI, and the need for revascularization. The type of testing that we did was, and then we also know that atherosclerosis is a well-accepted immune-mediating inflammatory disease, and we know that the pro-inflammatory adaptive immunity leads to a cascade of events that happens within the vessel that then could go on using to develop atherosclerosis. And so here are the inflammatory cytokines that really do play a role in the pro-inflammatory atherosclerosis as opposed to the anti-inflammatory. So to really answer our question about the women with FHA, we wanted to compare a group of women with hypothalamic amenorrhea that had to have 3 or more months of no menstrual cycles, had to have this hormonal pattern with low LH and low FSH and low estrogen. And we compared them to age-matched controls as well as BMI-matched controls. So women that were self-reported monthly menstrual cycles, we confirmed that they were ovulating by measuring a progesterone between days 22 and 24 of the previous month. We brought the normal control women in during days 3 through 5 of their menstrual cycles because we know that is when that woman's estrogen levels are at its lowest. We wanted to compare a low estrogen level day of a normal amenorrheic control to a low estrogen day of a woman with an age-matched FHA. Now that we brought in a third group, because if we thought this was estrogen, we brought in a group of women that were recently in menopause within 3 years, not on hormone therapy. So if this was an estrogen alone issue, we would expect those women with recently menopause to also have vascular dysfunction. None of the 3 groups could be on any hormones, so no birth control pills, no hormone therapy itself. And then after the initial study, we took the 30 women with functional hypothalamic amenorrhea and randomized them to receive a patch of estrogen at 0.1 of estradiol to placebo for 12 weeks. We gave them unopposed. All these women had uteruses. We felt as a DSMB, as an IRB safety, we didn't need to have monitoring unless there was excessive bleeding, because on average, these women had gone 12 months without a menstrual cycle. So they were their endothelial lining was felt to be very safe and thin for having 12 weeks of unopposed estrogen. The women that got active treatment were then given 2 weeks of progesterone, and then we measured outcome of vascular function over time. The measure of vascular function that we use was the EndoPAT machine, which measures reactive hyperemic index. And briefly, these are individuals that can sit down or lay down. Our patients did prefer laying down. As you can see on the distal tips of both hands, there is what looks like a pulse ox, but it is a little bit more extensive device. But when you turn the machine on, it blows up into a nice tight cuff and is able to measure peripheral pulsatility. And then on one of the arms is a blood pressure cuff. So an individual acts as their own control. The control arm is the arm that has no blood pressure cuff, as opposed to the woman here in this picture. It has the blood pressure cuff on the left arm. We put the blood pressure cuff also on the non-dominant arm, so we do ask about what handwriting and things like that. So pictorially here on the bottom is how we characterize a normal hyperemic response. This indicates the flat line indicates 5 minutes of occlusion, where we have to push up the blood pressure cuff to a systolic blood pressure of about 250. It's uncomfortable. It is not dangerous. It is just your hand sometimes feels like it's falling asleep. And then the most important part is this reaction that you get when you release the cuff. You should get this nice, beautiful feather-like response. And this is a normal reactivity of a hyperemic reactive response. On the other hand, this is an abnormal reactive response where you release the cuff and the endothelium is not responding and is not vasodilating to that rush of blood back into that distal area. The EndoPAT's the only FDA-cleared device for non-invasive testing for endothelial dysfunction. You could use it down as young as children, which we've done. And then the vascular dysfunction correlates with poor coronary blood flow, so in the cath lab, cardiovascular risk, and independently predicts events in women. So for our 3 groups, the average age of our hypothalamic women was 26. The age match controls ended up being a little older, as 30, but we ended up adjusting for that in all of our analysis, and the recently menopausal women were 53. The number of months since their last menstrual cycle was 12, as I mentioned, but there were some women that went almost over 2 years without a menstrual cycle. And then the recently menopausal women by design were in 3 years of their final menstrual cycle. Age of menarche did not differ between any of them, but if you look at their PSS scores, the women that were in the HA group, which have higher stress levels, compared to the controls and recently menopausal women, as well as PHQ-9 scores were statistically higher. And then interestingly enough, their FS12, their physical component was much lower than their controls, and then the mental component was much lower than their controls, but really did not differ between the recently menopausal women, were somewhat similar. The hormonal profiles of these women, so we saw women that had very low estrogen. And in order to confirm that these women didn't just have one low estrogen, 7 days after entering the study, we redrew another estradiol level. So you can see at the initial baseline, they were 29, and then they went down to 19. So we were very confident that these were not women that had just started ovulating or were elevating their estrogen at any point. Their total testosterone levels were also very low, as well as their LH, which I mentioned the LH to FSH ratio had to be less than 1. And again, this really just builds into the phenotyping that we did to really indicate that these were not PCOS-like women. And our reactive hyperemic index data found that the women with hypothalamic amenorrhea were statistically more likely to have low low reactive hyperemic index. In fact, it was 1 in every 3 women that had a low endothelial dysfunction diagnosis if you use the cutoff of 1.67. If you use the cutoff of 1.8, it was much higher, but again, it indicated that 35% of women with HA had endothelial dysfunction as compared and statistically different than controls in recently menopausal women. We also measured inflammatory cytokines, as I mentioned, and both of these results have been published in JCNM as well as presented at the Endocrine Society. So this results was presented at ASRM. The inflammatory cytokines. But again, you can see here, just standing back from the 10,000 foot level, you can see that in the peachy red that there were higher pro-inflammatory cytokines that were all statistically higher. Even for this small sample size, we were pretty shocked that there was this difference that was seen for IL-6, IL-5, IL-2. You could see that there's more need to investigate the role of inflammation in these women. So I mentioned the clinical trial. We then went on to evaluate, and we gave these women back a 0.1 estradiol patch. And why did I choose 0.1? And why did I choose estradiol? Well, estradiol is bioidentical. It's similar to what the body makes or the ovary produces. A 0.1 will give a serum level of about 100. So if you take an average monthly or 28-day women's cycle and would to take an average of about what that woman's average day would be like, although it fluctuates over that time, the average would be about 100. So that's the reason that we chose 0.1. There's no higher dose of a patch, and we felt it was also important to go through the skin because of the inflammation that we already had seen on the cytokines itself, as opposed to an oral pill that first pass metabolizes in the liver. We wanted to use more of a physiological ratio, so the advantage here was to go through the skin. So of those 30 women, 29 enrolled in the clinical trial. We had 14 that were put on patches and 15 that were put on placebo patches. And I circled the estrogen bump that we saw. It went from 31 up to 108 in those 14. So we were confident that these women were not only using the patch, we had all the women do patch diaries. They had to actually stick their patches onto paper so that we were confidently knew that they were using the patch. And then we also, so this was really the only statistical difference. If you look at the BMI, all very low BMIs, but their BMI didn't change over time. And drawing your attention to the cortisol started to trend downward in women that were on the patch of estrogen, and it actually trended upward in women that were on the placebo patch. But this was actually only a one-time draw. So while it is an interesting find, I think more long-term cortisol evaluation needs to be looked at in these women. These are p-values differences between the baselines, and here's p-value differences between week 12. The p-value difference between the deltas of cortisol actually was 0.051. The systolic blood pressure, diastolic blood pressure, these women all have very low heart rates, very low systolic and diastolic blood pressures. And again, you can see that the RHIs did not change. We were quite shocked, to say the least. My whole hypothesis was that estrogen could reverse the vascular health. And if you look at women from on the active group compared to the placebo active, to those that got the placebo group, really no statistical difference at baseline, no statistical difference at exit, and then we did the delta evaluation. So if you were on active patches, your delta over time was 0.2. If you were on placebo, it was 0.19. So almost a null statistical difference of 0.96. So we were quite surprised to demonstrate that estradiol replacement for 12 weeks unopposed did not improve vascular function in younger women with FHA after 12 weeks in a physiological dosing. ongoing research right now. So the current research that we are doing, and I'll touch quickly on this, is the current R01 that's funded by the National Institute of Child Health Development is looking at amenorrhea related cardiovascular health. And I mentioned it's hard to measure exercise through questionnaires. I learned that the hard way because I was asking how these women, how much exercise they were doing per day on average, and if they could rate their exercise scale on 1 to 10, how intense were they exercising? Everyone put about a 7 when they were doing an hour running on the treadmill and an hour additional of exercise. So the way that we are evaluating exercise is to use the Fitbit. So we are taking 100 women that have functional hypothalamic amenorrhea, and we have a 3-month follow-up of a deep phenotype. So these are women that come into Jacksonville, we pay for their travel, and we can actually measure their vascular function at baseline, and then at 3 months later, we follow up using questionnaires over that 3-month period. We have Fitbit tracking sleep, exercise patterns, heart rate variability, and then we are also measuring cytokines throughout that time, or blood measured markers. So the idea would be to determine who are the 1 in 3 that are getting vascular dysfunction. Is it your clustering of just stress alone, exercise alone, or disordered eating, or kind of a pattern of one or more? And now, since the evolution of AI technology, we're going to be using AI modeling to actually evaluate this analysis. This is what is our catchphrase for recruiting women. These are not women that go into the doctor's office. We are having to do a lot of social media and just have paper coming out on recruiting Gen Z. Um, this is a whole new way of recruiting when it comes to capturing the identification of women with this condition, but also using social media and the internet and podcasts to your advantage. So um, I learned early on that if you don't capture women within 1 click, they're gone. And if you don't capture them within 1 swipe, they're gone. So the catchphrase here was, did you know that missing your period may not be good for your health? And we have a community advocacy board at Mayo Clinic, and I had originally had, did you know missing your periods might be not be good for your heart, your health? And they said, no, you need to change that to heart. So this is a group of community members who evaluate your study recruitment information and they give you feedback as to if it makes sense and if it's capturing is the imaging that's capturing the as well as the way that we're using QR codes. So we're seeking women who miss 3 or more months of a menstrual cycle in a row, and these women also get a bone scan. They get to keep their Fitbit after the end of the study. We scrub it free of any research information, and they get vascular testing. And then we have a travel stipend up to $900 per visit for 2 visits. We've also partnered with a group called No Period Now What, which is an advocacy groups for women that's with this condition, and that's been extraordinarily helpful. They're out of MIT, and the doctors out of MIT, and so that's been a partnership that's allowed us to use it as a recruiting tool. We often speak on their podcasts about this as well. And then what we started is a Reveal, which is the registry for very early estrogen loss and anovulation. And one of the reasons we started this registry was out of the comment I was given to at the NIH during some feedback when I went to go out there to discuss moving from a K to an R. And one of the program officers happened to ask me, does this only happen in Los Angeles? I just paused and I said, no, this happens in other parts of the country. And I quoted Sarah Berga's research and the research that's been done on stress and the menstrual cycles, as well as the psychogenic amenorrhea that was the information coming out of World War II, and how there's a historical perspective here. But since I started this study and since I really started doing a lot of social media presence for recruitment, women are contacting me from around the world. And it made me pause and say, I think I need to open a registry. So we were able to open an online research registry using some startup funds that I was given when I moved to Mayo Clinic in Jacksonville. And what this entails is it really is starting to get at the prevalence, to understand the prevalence in other countries, as well as the diversity and underlying cause and risk factors, as well as other symptomatic complaints that these women have. And I'll share with you what some of those have been. If women do not have labs done, we send them this kit. This is a finger prick of testing for sex hormones. This was designed and by our research staff with a company called U.S. Specialty Labs out of San Diego, and it's a patented serum separator paper. And women have to prick their finger, and it's about 3 drops of blood goes within each of these cards, and then serum separates out. We get them back within 30 days. We could actually analyze all of the sex hormones as well as HCG quantitatively here down below. This is free of charge for patients that are in the study, and we have not had within a few countries, we've had some trouble with customs, but this is a company that we've worked closely with to get some of those resolved. To date, you can see pretty exciting. We've been open for 6 months, and we have 89 enrolled right now. We have over 200 consented. Those are waiting for their kits to come back or waiting for their first questionnaires to be completed. But you can see the list of countries that we have now, pretty vast even from Chile to Egypt to the Netherlands, Mexico, South Africa. So we have a grand total of 89. The average age is 27.8, which is very similar to the research of the 30 women from the K23, but the number of months of amenorrhea has been 34, as opposed to 12 that we had in the original grant. The average BMI, very similar, 20.6, and they get baseline surveys, 3-month surveys, 1 year for the next 5 years. So again, it's to try to understand not only the prevalence, but also different conditions or complaints that there is, as well as pregnancy outcomes that we're looking at. Speaking of pregnancy outcomes, we just had an NIH proposal approved to look at new mom to be, which is an NIH registry of pregnancies in the US as well as offspring. And it has been noted that women with irregular menstrual cycles are at higher risk for preeclampsia and low birth weight. Irregular cycles have been associated with increase of hypertensive disorders in pregnancy and are also associated with gestational diabetes. So we put a proposal together because it was based on the fact that adverse pregnancy outcomes and endothelial dysfunction is always the lovely argument, is it the chicken or the egg? Does endothelial dysfunction cause the adverse pregnancy outcomes, or does adverse pregnancy outcomes result in the endothelial dysfunction? But you can certainly see here in the green that endothelial dysfunction has been associated with fetal growth restriction. And then any kind of immune dysregulation has been more associated with preterm delivery, as opposed to things like oxidative stress and preeclampsia, chronic hypertension. And then does all this then lead to increased cardiovascular disease outcomes? And so we're taking a look at that data right now in the new mom-to-be data cohort. And so we're looking at menstrual cycle regularities and length. So similar to what they did in the Nurses' Health Study, that was the original data that I showed you, we cannot deeply phenotype them into having FHA prior to their pregnancy, but we can ask about their menstrual cycle regularity and lengths prior to their pregnancy and look at both cardiovascular risk factors and adverse pregnancy outcomes. So stay tuned for that. This summer, we're launching Brain Arch. So Arch is the atherosclerosis-related cardiovascular health study that's been going on. But we know that low circulating estrogen levels coupled with amenorrhea have been associated with cognitive impairment in animal studies and in some small human studies. The registry really pushed this forward because there was 4 questions about cognition on the registry, and over 50% of the women now of that 89 report cognitive impairment or difficulty concentrating, remembering daily tasks, or actually going about their day-to-day activities. Women with estrogen deficiency, we know, have cognitive deficiency, so premature menopause as well as Turner's syndrome, if they're not replaced. And there's a suggested role for replacing enhances cognitive skills. And so in addition to how does the estrogen and endothelial dysfunction that we're seeing in the periphery via reactive hyperemic index, how does that indirectly impair the brain endothelial pathways, including the role of low estrogen and high cortisol? So one final thought here, I'm going to leave you with this. If you put in functional hypothalamic amenorrhea into PubMed and you just filter by clinical studies, even systematic reviews, from 1968 to 2024, that's how long you can search back, there are only 109 results here. Now in 2020, as opposed to polycystic ovary syndrome, you can see this dramatic upslope and interest that really started in the 1980s and has continued on to the current stage. And there's over 2,900 publications in this space. Now, the Endocrine Society put out a functional hypothalamic amenorrhea position statement in 2017. And in 2017 to 2024, there's only been 13 studies to date. So it does beg to argue that we are in a deficit state. It is a condition that is common in women, has been associated with clearly systemic consequences and health outcomes, and is not being studied. So, in conclusion, estrogen loss is a key in reproductive lifespan. It may impact their trajectory for cardiovascular risk. Our study, as well as other studies, demonstrate endothelial dysfunction. In our deeply phenotyped cohort, it was 1 in every 3 women. And it's not probably just attributed to estrogen alone, or that estradiol patch of 0.1 should have reversed at least some of it or mitigated some of it. We can argue that a dose wasn't high enough or perhaps used long enough, but I think if we were to see some sort of signal, we should have seen something change, and that p-value of 0.96 is pretty telling that it wasn't. Future studies that we're working on really to deeply phenotype that FHA cohort and identify who are the ones so we can target for CVD prevention and for possibly the systemic impact overall. So this is a coined quote from one of my podcasts I did about 2 years ago, and it really is the menstrual cycle should be considered a vital sign for our health. So thank you so much. Here's my email. If anyone has thoughts, I'd love to have a discussion, but also questions. But if you would want to reach out to me about a collaboration or even looking more deeply into this group of women, I would be happy to really discuss.
Great. Thank you so much, Chrisandra. That was very interesting. And while we're waiting for questions, I'll start off with one. No, I thought the physiology is so interesting because usually we think of hypercortisolism associated with weight gain.
Mm-hmm.
And I think it's very interesting that in post-menopause, you don't see the high cortisol, but you usually have weight gain, versus in the FHA women that have higher cortisol, but they're slim body habitus. Any thoughts on that?
Well, I think not all women will gain weight in midlife equally. And so I don't think that there probably are women that bump their cortisol in menopause. It's just not in that recently menopausal stage, perhaps. But I also think that the physiology behind the pathway of why the GnRH pulsatility and why CRH goes up and then the activation of the cortisol pathway is that stimulation of suppressing HPO and activating HPA, I think is really needs to be stressed that these are not just women walking around without a menstrual cycle. They're walking around without a menstrual cycle and elevated cortisol. So yeah, we did not see that in those recently menopausal women with the cortisol levels. And we also did not see that with their cytokines either. So it might actually be a driver for the inflammation as well.
Dr. Kayumi, do you have a question?
Yeah.
Yes.
Thank you very much, Dr. Shufelt. That was amazing.
Thank you.
Very interesting. I just had a couple of comments and some questions as well. So this replacement with estrogen and not seeing improvement in endothelial dysfunction is not new, as you probably know from the literature. Many years ago, we have done some studies using just FMD type of, well, actually it was infusion studies.
Yep.
Measuring acetylcholine-dependent responses but this was done in postmenopausal women as opposed to this syndrome. But acute administration of estrogen, estradiol, improves NO. But you do that for 3 months and it doesn't do anything. So there is a very different reactivity in terms of endothelial function with acute versus chronic administration of estrogen. So this is probably what you're seeing as well, except it's a different technique. And as far as this technique is concerned, just some comments about that, even though it's sold as an endothelial function measurement. Most of the reactive hyperemia is endothelium independent. It's due to accumulation of metabolites like adenosine and all sorts of things, hypoxia, etc., that you get the vasodilation. A tiny amount of it is NO dependent. So sometimes it's obscured because of all these other things that are responsible for reactive hyperemia. But the chronic administration may never improve these things because of just the way it is with estrogen replacement. And then physiologically, I've just wondered whether if you're just correcting this downstream, one of the many consequences, I guess, of this syndrome, would that lead to feedback and correct this inhibition that's occurring in the hypothalamus and those pathways that you mentioned? I'm not sure what you'd expect. Or is there any experimental data to show whether you'd expect that to normalize everything just by replacing estradiol?
I don't think by replacing estradiol it would reverse that condition, but I do think certainly the downstream effect of reversing the underlying cause. That's also the question that we're getting at is if you reverse the cause, does it reverse the vascular health? We certainly know we're also collecting bone DEXA scans, so we're correlating bone scan loss to the vascular health as well, and also seeing a signal. We're also seeing a signal for length of amenorrhea, as you could imagine, and vascular health. So it's a point well taken about on non-endothelial versus endothelial dependent pathways. It is my next area is to go into the brain and do the cerebral vascular reactivity testing using CO2 in the magnet to see if there's anything in these women's that really does demonstrate a structural change or even a vascular change in the brain because of all the cognition and cognitive complaints. I think because we have the opportunity to look at these women over 3 months periods, and some of them I don't tell them, don't keep doing what you're doing to get your period back. Some of them are in counseling, some of them have nutritionists, some of them are working with coaches to try to regain their period. And we have a small handful of women that have regained their period during that 3 months. So we have an opportunity to look at what they're doing and to see if it's changing both their cytokines or their vascular measurements. And so far, we're not seeing that. I don't think getting a menstrual cycle back for 1 month, you're probably going to see that big of a shift or big of a change. It might be a year or two from now. But what we are looking at in the Nurses Health Study too is we have taken out those women with high BMI, and that data that showed the Nurses Health Study 2 was associated with CVD outcomes and CVD mortality. We've looked at that data now and are about to publish it, have already presented it at the AHA, looked at those women that reported having irregular cycles between the ages of 25 and 34, and then followed them now going forward for 25 years. And strictly low BMI had to be less than 19. These are who we're following. And they reported amenorrhea during that period of their life compared to women who had their menstrual cycles. We're seeing a twofold increased risk for cardiovascular disease events in those women as well. So while these markers that we're using might seem simplistic, at least in large databases, we still have a convincing outcome that there is a signal still there. And I think from my perspective, it's just such a ignored, I don't even know if I can say ignored, but it's such a difficult cohort to study because they aren't going to their physicians and they don't think they're sick. And if they're so busy in their young lives, I've talked to so many of them now that they just are like, okay, I'm not pregnant. Okay, I'm not giving my period. Some of them think that's an advantage. And they're too busy with their life that they're like, oh, I'll just go on. And oh, yeah, 2 years later, I think I want to get pregnant. So then that's when they actually seek treatment for this condition. And, is it 3 months? Is it 6 months? Is it 12 months that is really doing all the damage? And the Endocrine Society says after 6 months of amenorrhea, these women should be put on estrogen for their bones. But we're showing that that's not changing any vasculature. So thank you for your comment. And I know your name very well from working with WISE.
Chrisandra, are you also measuring sleep? Because, these are sort of type A personality, at least
Yeah.
some of them. And I'm just wondering whether, it's the importance of sleep and circadian kind of disruption and
So, yeah, and this is where the advantage of Fitbit comes in, because we are giving them Fitbit. We're going, if anyone's done Fitbit research, what you do is you give them a Fitbit. A separate company is called Fitabase, so that's the cloud that stores all of the data. And you can go in as the PI, I can go online to fitabase.com, put in my username and password code, and it'll pull up all of my patients that are enrolled in my study right now. The advantage here is I know whose Fitbits are starting to die, and I can send that person a message through the Fitabase saying, please charge your Fitbit tonight. My clinical research staff does this. They check and make sure everybody that's in the study actively has a charged Fitbit. But the Fitbit allows us to know what time they go to bed, how many hours they sleep, are they having disruptive sleep, as well as activity levels, and activity levels during the daytime, during the nighttime, into mild and moderate. It classifies them into low, mild, moderate, and high levels of activity. We also have heart rates, and the recent update on Fitbit is they have heart rate variability. And this is where Vas and I were talking earlier about, is that an accurate measurement? Well, it's just a tool right now that we're using. They have temperature sensitivity as well as O2 sat now. So I think it's a remarkable tool to look at. Outside the research walls, remote monitoring we know is important for clinical care as well. But I think all of this information is going to come together in this AI modeling. Right now, we have looked at some of the data. I haven't looked at all of it clearly because it is very large, but we have enrolled 65 patients, so we're about 2/3 of the way there. And so we're trying to do a hard stop right now and just do an interim analysis so that we can get some data to go forward.
great. Is there a question from the audience? Somebody's raised their hands. Dr. Lapu?
Yes, good talk. I just want to go with Dr. Koyumi because raising the question of FMD, and then we know, as Dr. Koyumi mentioned, even for the way you're putting your obstruction, whether the upper curve or the lower, make a big difference, become non-independent, more ischemia than anything else. Now, the question for Dr. Koyumi for comment, you think the PWV, pulse-wave velocity, could be a good technique in this case?
These are measuring different
Mhm.
different measures of vascular function. They're not overlapping usually.
Mm-hmm.
They can be, but they're not necessarily. Pulse wave velocity is measuring large arterial stiffness.
Exactly.
And whether this group even has abnormality in that would have to be seen. I don't know.
We
I don't
did
know.
we did PWV in
You
a
did?
small
Okay.
group of them, and to see if that could be another monitoring tool as well as augmentation index. And these women their blood pressures are so low, their pulses are so low. These are not
Yeah, I suspect.
they don't have the chronic condition that would set you up to have large arterial stiffness or central arterial stiffness. So
Exactly.
that was one of the reasons that it is hard to measure vascular health in young women and in terms of overall future health, and that's why we chose the RHI. But I would love to hear other thoughts on that. The other thing we talked about doing was endothelial cell scrapings to look at actually the endothelial cells itself.
Okay. Thank you.
Yeah. The other thing about this condition is because it is central, it's in the brain, as opposed to the ovary itself, as opposed to PCOS. PCOS, you get a high testosterone levels for a period of time, which then lead to hypertension and diabetes and obesity. So you get these chronic cardiovascular risk factors leading up to getting a lot of the amenorrhea, and then you get the cardiovascular events that you see with PCOS. This is the opposite. You get the amenorrhea first, and then you probably get the consequences of the amenorrhea and the hypercortisolemia after, like the type 2 diabetes signal that we're seeing in the Nurses Health study, these aren't obese patients, so that can't, and they're not hypertensive patients, so that's not accounting for their CVD risk. So is it just the cortisol or the inflammation pathway?
So Chrisandra, just to follow up,
Yeah.
you said that these women can be highlighted, as it were, from their profile as being ones that exercise too much
Yes.
and eat too little or have a strange diet
Yes.
and are very thin and maybe stressed out. So do you think that's what's driving the whole thing, or is there something wrong with the brain, which you're about to investigate, that also makes them eat more, eat different, and exercise more, and so on? You know what I mean? There's a fundamental problem even higher than these habits. Or should we be advising these people not to exercise so much and eat a normal diet? God forbid, you know.
Yeah.
Or have people have done this experiment themselves? They've kind of slowed down or whatever.
And this is the $50 million question, is how do you treat these women? Because how do you tell a 26-year-old to eat more or exercise less or, quote, stress less? Especially as I open this worldwide registry, when I'm getting patients that are, or participants that are in situational stress that they can't control. So I think and there is a certain, and this has been studied by Sarah Bergens, who's a reproductive endocrinologist, and looking at personality disorders, there's a high level of perfectionism in this cohort. But I will say there was an eloquent study that Nanette Santoro just published looking at U.S. combat veterans. So they took about 70 U.S. combat veterans that were going into basic training. So that's a form of stress and excessive exercise. And they looked at their hormonal milieu prior to combat training. And then they looked at it at the end of basic combat training, and 72% of them had become amenorrheic and ovulatory. So that's a conditional situation. That's not a brain situation. But then I've talked to Stephanie Seminari at Mass General, who, her role and her research on kisspeptin shows that the receptors can change, and then does that the loss of GnRH pulsatility then change? Actually, it atrophies. Could that actually be causing an atrophy of the hypothalamic area and all of the nuclei that go along with that? So I think it probably is a combination of both, but it certainly needs to be investigated a lot further, because I clearly get calls from patients or participants that are frustrated because they don't know how to get their periods back. So there probably is the behavioral is the initial trigger. But then if you continue that trigger, is there long-term health consequences that impair you from regaining your menstrual cycle once you fix the underlying condition that's in the level of the brain? Then there's also been some studies on the genetic propensity for this condition, because what's stress to one individual versus another, and how that role can play into the brain. But probably this is why it hasn't been studied. It's complicated. These are all excellent questions that we need to answer.
Thank you.
Thank you.
All right, we're past 3 o'clock. So if there are no other questions or comments, thank you everyone for joining. And thank you so much, Chrisandra. That was really fantastic. And we learned a lot. You gave us a lot to think about.
Thank you so much. Have a good day, everyone.
Thank you.
The preceding program is copyrighted by Emory University.